Hi, I'm Dr. Eric Westman, and this is the Keto Made Simple podcast.
Hi, Dr. Eric Westman here again, and it's my great pleasure to be here with Dr. Angela Stanton. I've wanted to talk to Dr. Stanton for a while now, and you'll see why. I've referred many of my patients, maybe even you, to her book, and there's a lot of great feedback that I've received, and I always wanted to know how it got started. So thank you for being with me today.
Thank you very much, May. The honor is on me. Really happy. I've been looking at your podcast for a number of months, and I really enjoy what you're doing.
Well, thank you. It's rewarding to be able to help people, is it not?
Oh, very much so. That's why we're all doing this, right?
Well, you're really kind of my go-to person for migraines, for things that people are asking me in the clinic all the time. But, that was one of the things that I'm using a low-carb keto diet for weight loss mainly, diabetes reversal mainly, and people come in spontaneously telling me their heartburn is gone, their irritable bowel syndrome's gone, and many come in saying their migraines were gone. Now, I didn't formally diagnose them with migraines, but so they'll just tell me their headaches are better. And that's interesting. There's a low carb or keto overlap with your program. But before we get to that, how did you get into this in the first place? I seem to glean that it was from your own problem with migraines.
Right. I've been a migraine from very early on. I was probably in my early teens. I would say maybe 11 when I started getting migraines, but my migraine presented differently. And excuse, I have something is really bothering me here. And these, the kind of migraines that I had at that time were what I now call child presentation of migraine, which is different from the standard migraine. And then right around in my late 20s, when I was officially experiencing my first real migraine that you would associate with a migraine, with a headache and everything that goes with it. And I was diagnosed shortly after that with migraine. And so I'm 70 now. So we're talking about over 50 years of struggling with migraines. And so I was in academia, teaching at university, working in the field of neuroscience and economics. It's called neuroeconomics field. And I just said, okay, that's it. I can't teach. I would have to lie down on 2 chairs pulled together in my office between classes. And, university classes have 300 plus students. So you're talking about big lecture halls, lots of work, and you have to pay attention. It's not that simple. I said, I can't do this because in between classes, I would be sleeping, taking a triptan or some other medication. And I didn't consider myself to be a fair teacher as a result. I couldn't really focus. And so I quit all that. I quit teaching, quit everything associated with academia, and I decided to focus 100% on migraine. So that's how I got connected to migraine, my own experience, but then it evolved into something completely different, which is where we are now.
Where was this? Where were you university professor?
Okay, so I was teaching at Berkeley at first, and then at Chapman University, and then I moved to Germany, actually, to Max Planck Institute, and I was working for Max Planck as a visiting scholar and doing some research. So I got my PhD late in my life because I had children and I wanted to have them grow up a little bit before I returned to education. And so I started my education from the bottom I think I was 35. And so I got my PhD when I was, 54 or something like that. So it's a late start and a late finish. And so I don't have that historical long academic career that a lot of people do because I haven't been in academia that long. So most of my work was clinical trials and research.
Well, but the personal experience, and so you were trying to solve a problem that you had. I assume you went to the traditional treatment centers, and,
right.
and what have you learned along the way?
Well, a couple of things. First of all, it's very difficult to diagnose migraine because everybody thinks of migraine as a headache, but actually migraine is not a headache. And so if wherever a person goes who has migraines may or may not have a headache associated with that migraine, going to the doctor will automatically be assumed to be a migraine sufferer with migraine headaches. And so the treatments are basically treating the headache, but assume you're on a medication for your headache, and maybe your headache is even gone as a result of the medication. Your migraine is still there because the headache is just a symptom. And so this is just a symptom treatment. So I didn't find the medications working as a result, even if they worked. And triptans were the most commonly used and prescribed at that time. We're talking about 20, 30 years ago. And they would work about 50% of the time. And so that's the other question. How come they aren't working the other 50% of the time? And some of the medications that were at that time available, they were all for other diseases. They would be for depression or heart disease or other conditions and not for migraine. There were also some that were for epileptic seizures and not getting closer to migraine, but still not it. And so I thought that there was a huge distance between what I had and what science thought I had. And so this was the one that initiated my research into digging up what is it that science is missing, what is it that medicine is missing, what is migraine to start with. And so when I quit a university teaching, and of course being a scientist, your work is to research. And so I was researching, so I would hit all the books, all the academic articles, and because I have a very unusual educational background. So most people just go to your undergrad university, getting your bachelor's, and then you kind of sort of know what you want and you pursue that degree. My case was very different. I actually was going to become a PhD in mathematics, which is very different. But this also gave me a mathematical mind to research things. So my looking at medicine is coming from math and physics. It's not coming from medicine, at least at the beginning it wasn't. And so I didn't look at it the same way as doctors or researchers look at it. So I started to discover things that, wait, this isn't even mentioned. This is not even near. So the literature that I was looking at were not just medical literature and not just migraine, but I would look at literature on electricity, literature on physiology from the perspectives of physics, not from biology, and looking through all the non-biological kind of fields and looking at the different stops within the human pathology. So if you're looking at, for example, our brain, yes, we have neurons, we have myelin sheaths, but what do these do and how do these work? You can't really understand that looking only at medicine or biology. You need to look at physics, chemistry, engineering, mathematics. You have to understand all the things that are associated with the atomic nature, basically.
Also, so is it, what are the most common forms, or how would one of my patients know if they had a migraine, if there's more than headache? What are the most common manifestations?
Okay, so you have the most common manifestations is before a migraine, a person will urinate, excess urination, and it's very clear. It has no toxins in it. It's just pure water. So it's basically an electrolyte balancing by our kidneys. You're in trouble. Second one is most every migrainer gets a little bit dizzy, gets a little bit nauseous. Some of them downright vomit. Some get vertigo, so they can't even sit up or stand up. They will fall over. Many of them, they'll start slurring. They may not recognize our spouses or children. They completely have a lack of conscious understanding of the world around us. You may not remember where you are or what you're doing. You may not be able to, one of my very common things is that I tend to increase my speech volume, but at the same time become very sensitive to others talking to me. So if my husband is talking to me, suddenly his voice appears to increase, even though he didn't change, that would be a symptom for me. That's a prodrome. And so you will have a lot of symptoms and prodromes that have absolutely nothing to do. And of course, the aura, which is very well understood, so to speak, by a majority.
What does an aura feel like if you have one?
Yeah, actually. So there are two things that I should tell you about the aura. One is that everybody thinks of the aura as a beautiful, colorful, or black and white zigzag lines. But actually, any kind of a visual disturbance can happen, and those are all auras, even if they call it something else like scintillating scotomas or something similar. But those are really all visual disturbances representing the exact same thing, just different way of representing it. And so they feel really scary. Some of them are beautiful, and some of them are really scary. Like if I sleep and suddenly I get a visual huge, like think of a reflector from the back of your brain shining onto your eye. So it's not coming from here. You can actually see it coming from the back, but you don't know what it is. It's a huge light. It's like a lightning. It's like just on and off. That's it. You will wake for that, and you don't know what it was. And so oftentimes I look, was there lightning? Is there a storm? But no, it's within the brain. And so there are many, many manifestations.
All sorts of neurologic, even one might think those were like transient ischemic attacks, pre-stroke almost. And then even the urination was something new.
Right. And then yawning, a lot of yawning. Okay, so that's an excessive need for oxygen. And just being out of it, really. Or being over, like I have people who, for example, tell me, I felt so good, I cleaned the kitchen tip to toe at 10 p.m. last night. Well, is it really normal to clean the kitchen at 10 p.m. at night, tip to toe, all the way from floor to ceiling? It's not. So that too is a sign that a migraine is about to hit. So there's a lot of different things, very difficult to discover that you have it.
So did you find that the literature you were looking at had answers for this for you?
No, not at all. So for the aura, they did, but it's really interesting that the very science that is looking at the aura and is looking at the processes in the brain, understanding what they are, is not able to connect the two. It's really amazing for a mathematical brain person to see that on the one hand, we have what is called the cortical spreading depression. I don't know if you're familiar with that. Have you heard that? Okay, so let me explain that a little bit so that you know, and then but just to connect that the cortical spreading depression is actually the visualization. The aura is a visualization of the cortical spreading depression. So the cortical spreading depression is that before you have a migraine, your brain has a built-in CPR, so to speak. So it can sort of initiate what is called a depolarization. And a depolarization in terms of brain talk is basically sending a wave of sodium across the brain. So it starts at one point and it goes through every single neuron in one hemisphere of the brain from beginning to end. Where it starts, that may vary, that I don't know. And where it ends, of course, that too varies, we don't know. But it touches every single neuron in the process. And I explain it as, hello, are you there? Are you awake? Keep on going. Are you awake? Keep on going. It's checking and passing on the sodium to find the place or places in that one hemisphere where the electrolyte voltage gated channels are not working. And so this is a huge wave of electricity. Think of it as an ocean wave. So it's very similar to seizure. So in the case of a seizure, you have the exact same thing happening, but it's like a giant bomb taking off in one place, and it's activating the neurons in all directions at once. It's a huge hyperpolarization. In the case of a migraine, it's the exact same thing, but rather than going off in one place to all directions at once, it has itself like a wave, touching every single neuron. But it's the same hyperpolarization, but in a different fashion. So it takes, depending on the size of the brain, the typical speed is about 2.5 millimeter, I believe, per minute. So it takes about 30 to 45 minutes for this period to go through. And for those people who see the aura, this wave is heading through the brain in an angle that hits the occipital cortex in such a way as it is assumed to be a signal coming from the eyes. And so the occipital cortex, exactly, it's just translating it to something that the person could be watching and sort of kind of tries to make sense of it. So hence the forms and the symptoms and the kind of shapes that we can see, but they're always associated with the area of the brain, the neurons specifically, where the electricity is traveling. And so this is why the scintillating scotoma sometimes can appear little points and dots. Sometimes there's a blind spot in the middle. That would be the part of the brain that is not working, where the attempt is to reach.
To translate it, scotoma is a seeing something, a speck in the eye or floater. Yeah,
it's not a floater because it moves differently. So if you've ever had a floater, then you know that when you blink, the floater so kind of drops and then goes back up again.
Or it keeps going away.
Or it keeps going away, exactly. And it also changes shape. So it can be smaller, bigger, and it can be moving. And you can literally, if you just look and you don't move your eyes, you can see it sink. So that would be just a simple floater. But when you're looking at spots, for example, that may be appearing floating, and you think are floaters, but they're a part of this cortical splitting depression or auras, they aren't floating away. They just stay stationary. And if you move your eyes, they aren't moving. They're moving exactly with your eyes. So everything remains totally the same, and they're moving with your eyes. It's a very different way of looking at it. And they can, yeah.
I was just going to say there are a couple of connections I'd like people to make already. One is the connection between sodium and electricity.
Right.
Because and you say things very fast, but the depolarization is part of the electrical activity that's going on. And the sodium is integral, is a huge part of this translating the chemical into electrical energy.
And thank you for slowing me down. I'm famous for
that's okay. Well, so many people are not aware of that. How could salt or sodium be important in the brain? That's the connection there. And the other keto connection, of course, is the use of a keto diet to influence children who have epilepsy.
Right.
So that a subset of all of childhood epilepsy can actually be reversed. Many get better, but most, some can actually be reversed because of the lack of a glucose receptor. But so I just want people to make the connection that, yes, a keto diet, we know it can affect the brain, the epilepsy reversal, and then the electrolytes turn into, that's interesting, electrolytes, electrical energy. Think of the sodium, potassium, magnesium as things that are important for electrical activity.
And I'm glad that you brought up the epileptic children because in the ketogenic diet connection, because we haven't touched on this yet, but the connection with glucose and carbohydrates in general. So if I'm looking at epilepsy, which is just more than one seizure, basically, so we're talking about seizures. So if you're looking at seizure and migraine, I noted earlier that they're pretty much the same, just the manifestation differs. And so you can get an aura even with epileptic seizures. It doesn't change. You can get an aura with a traumatic brain injury, with just about any kind of a brain tumor. You can have an aura even then. So it's not specific to migraine, even though we think it is. It actually isn't. And what you have described in terms of the ketogenic or ketosis, state of ketosis or ketogenic diet, the important connection to sodium is that this one sentence that is in the medical manual that seems to be completely ignored is that as glucose enters the cell, sodium leaves that cell. Sodium and water both experience an efflux. In fact, if somebody has ingested a tremendous amount of salt all of a sudden and gets into danger and they call ambulance and take them to the hospital, what do they give them to reduce the hypernatremia, the excess sodium? They give them sugar because the sugar is going to remove the salt from the cells. And this capacity of the sugar is the connection to the brain in those so predisposed that they can't use glucose for whatever reason. That's part of it is genetic, that they can't use glucose properly by their brain. And this over time, of course, is additive in the case of migraine. So you can see that children aren't necessarily born with migraine, but they evolve with migraine over time. And so the brain evolves a bigger and bigger carbohydrate intolerance as a result of the sodium leaving when eating glucose. And in the case of migraine, there is a genetic connection. In addition to this, is that if you go to the Human Genome website, which is genecards.org, And I peruse that website very much because you can type in migraine and you get all the SNPs, the variants, genetic variants associated with migraine, and they're ordered according to importance or frequency of how it affects migraine. And the first 3, 4, for the past 6, 7 years, I've been following the Human Genome Project. The first 3 or 4 are all voltage-gated sodium channels, voltage-gated potassium channels, and the most important is the voltage-gated sodium-potassium ATPase channel. So this channel is the one that balances every single cell or neuron's membrane potential to return to normal. And in the brain of the migrainer, these 3 are variants. These are the most important variants. So even if the migrainer were not carbohydrate intolerant, which the migrainer is, but assume she weren't, she would still have a difficult time resetting the electrolytes because of these variants. So it's a combination of these 2.
Very interesting. Wow. So then how did you come across the path of helping yourself through this?
Okay, so I went straight to the electricity because that is so important in the brain. And I said, okay, let me try. What happens if I add salt? Is that going to help me just simply taking more salt? Because we live in a society of salt reduction in everything. Reduce salt foods, reduce salt everywhere. Salt is not recommended. But I said, okay, so what if I don't reduce the salt? And so I started to take, rather than increasing salt in my food, because I don't like the taste of salt, I added a little bit of salt just to my tongue and swallowed it with water first thing in the morning when I would wake. And to my biggest surprise, I would wake with migraine nearly every single morning. And to my biggest surprise, it would take away the migraine, not permanently, but it would tremendously help, much better than triptans. And the success rate was nearly 100%. I said, whoa, okay, so there's something to this. And
well, I have to ask, how much salt?
It was, at the time, it was a little pinch. And so pinches vary, of course, between people. It can be very tiny to very big. So my pinch, I would say, yeah, it's about 1/8 of a teaspoon. Now I know because I measured it. So it's not a big amount, but it was uncomfortably big to swallow it. So after a while, it becomes really uncomfortable. So hence I switched to salt capsules later on. But so this proved, and I did this for a couple of years before I was able to move past it and continue in other territories because I didn't yet understand the connection. I understood that it was helping with my migraine, and I understood that it has something to do with the electricity, but I didn't yet understand the full scope because at that time, I was not involved in nutrition at all. I was in neuroscience, so I'm partly a neuroscientist, not a full-fledged one, but part of my PhD, half of it was neuroscience. So I said, okay, so I want to understand in neurology, but just like everybody else went down on the rabbit hole of symptom cure at the beginning. So it was just taking salt to reduce the symptom or make the symptom disappear, but it was not yet understood by how and why that happened. So it took me a couple of years. And in fact, I have a Facebook group that I created, which is now 10 years old. And the first year of the migraine group, we still ate bread. We still ate potatoes and starches because I didn't yet understand any of the connections. So it took me a long time to qualify even the salt because it's not clear. It's not just because you eat salt, it doesn't mean it's going to end up in your brain. I mean, there's no direct connection, right? And so it took me some time to sort of be able to prove it to myself that it did and explain how it did it. And then so once I explained that, again, being a mathematician means you have to prove there's just no alternative. So you have to come up with a logical explanation that cannot fall. And so it took years for me to get there. And I had some friends who joined me also taking salt. I turned really lucky because my mother was ill at the time, and we had a nurse who came in and stayed with us every day for so many hours, as she was a migrainer as well. And so I asked her to take it, as so she was taking salt, and her migraines also disappeared. So I said, okay, so it's not by chance.
Case number 2.
Case number 2, doing nothing else, just that, right? And then I wrote my first book, which is no longer sold. That was just me. It was basically, this is what I did. And a lot of people started to read it and joined my migraine group at that time. And it started to appear that it works for other people. And that's when the whole work started of what actually really is happening and how to make this a permanent fixture of our lives.
So how did the low carb, how did the diet get into this equation?
Okay, so it came into the equation actually quite accidentally. Okay, so because I still didn't see any connection whatsoever to nutrition at that time, and I have a condition called POTS, which is a postural orthostatic tachycardia, which is very common for migraineurs. And so I was taking a medication for that, and which was a heart medication, but it was a beta blocker very specifically to reduce the heartbeat speed, not the blood pressure. And unbeknownst to me, this medication has a huge interaction with ketosis. I didn't notice, and I went on ketosis just to see, but what is that thing, right? And in fact, I did it the right way. I went to Kaiser. I belong to Kaiser as a medical company. And I said, okay, please teach me ketosis. And so they said, well, we only have ketosis for children. I said, that's fine. Just send me through the rabbit hole. I want to understand what ketosis is. So they took me as if I were a child. And they said, okay, they put me on MAD, which is a modified Atkins diet. It's a 4-to-1, which means you're eating 4 times as much fat in calories as you do in protein or carbohydrates. And he said, okay, this is what you do, and keep on checking with us so that you know what you're doing. And this is how you measure your ketones. And that was a urine measure at the time. And so I started it, being on that heart medication. I had no idea. I ended up with such trouble with my heart from that, tachycardia to the roof. It was really bad. And it took 3 doctors to figure out the connection of what actually happened. And that was my first time. Then I said, wait, if that can do this to my medication and my heart, what else can nutrition do? What's the connection? So this was the connection. And this was also the start of my understanding that there is much more to ketogenic diet than just eating that way, because it is a huge biological change that can change how medication works, right?
Yeah.
And so this was the first time when I realized the connection to food, and then I started experimenting on my own. Everything started with me, little at a time, to see what I can do and what I shouldn't do. And by that time, I had, I would say, maybe about 1,000, 2,000 people in my migraine group. Currently, it's almost 17,000. And they were also, and I would tell them, okay, I did this, and this is what's happening. If any of you try it, what happens to you? And so this was more of a give and take in the Facebook group of understanding how other people react, and if there was a difference, if they were similar. And it was really interesting to see how basically all of the migraineurs who at the time were in the group, we were like Popsy twins. It was really interesting how we all reacted the same way to the same things. It was rare to see somebody have a different reaction. It was fascinating. And so this allowed me to further understand the connections and also to be able to generalize to other people a little bit freer than I felt before. And I have run a lot of surveys in the group. I have this, do you have this? Like one of the biggest signs of a migraine prodrome is one eye becoming smaller than the other. It's really fascinating. It's just totally normal.
The pupil size?
Yeah, the pupil. It's a tortoise. It's a complete tortoise. It's like you can barely open your eyes. So I would go like this. And also the under the eyes of puffiness or the overt uneven. So it's not an even look. And my husband...
Ketosis is the name for it.
Yeah, ptosis, right.
A droopy eye.
It's a droopy eye, but it's temporary. So unlike ketosis where you have it permanently in the condition, this is just temporary, and it's a prodrome. And I didn't notice, but my husband would tell me, I've been married for 50 years. We're celebrating this year. So he's familiar with my face really good. And he would tell me, you have a migraine face. And I said, what is a migraine face? And he said, I don't know, but your face changed. You have a migraine face. And it took us a few years to discover that this was the biggest difference. And of course, everything was a little bit droopy, but that was the one that you could really see changed significantly.
Well, I have to say, I really like the, many people start with fixing themselves or, improving themselves, and then starting a group where you've actually learned a lot from the group that's been getting larger and larger over time. And, it's one thing to read a book by someone who fixed themselves. There are diet books like that. But it's quite a different thing to have someone who wrote a book that's based not only on yourself, but on these thousands of people. Now, it doesn't tell us if it will work for everyone, but it tells us that it will work for at least this many people, and that's a lot of people, I think. So when did when did magnesium become important in your mind along this journey?
That was probably around the second or third year of already the group being in existence, because then once I understood the electrical part of it all, then I started to get into the biology part. And then I discovered that magnesium has a role of actually feeding the ATP to these channels, the voltage-gated channels that open and close. And so the magnesium, if I need sodium to open the voltage gate, but I don't have enough magnesium, I'm still stuck. And so I said, okay, magnesium is equally important. So potassium is not important, by the way, because potassium is, it's important in terms of the closure. So there are some conditions where the gates don't close because there isn't enough potassium, but that was not a problem for migraine sufferers. It was more just focused on the sodium and on the magnesium. But there's a caveat with the magnesium, which I later discovered, is that because magnesium is the one that takes the ATP to these voltage-gated channels to open the door, if you take your magnesium at the wrong time, then your channels are going to open. That's again a bad thing. And so I did not realize the connection until I discovered that migraineurs taking magnesium at night, like many people take magnesium at night to get better sleep, migraineurs get nightmares from taking magnesium at night. And so there is another connection, again, to the voltage-gated channels very specifically, is that we can't sleep from magnesium. It keeps us awake. So it's a complete opposite from how it works for other people. And so it took me a couple of years to understand how that worked, why it worked, and when to take the magnesium and how much magnesium to take. It took me some time to I would say, not as long as the discovery of the salt importance, but it took quite a bit of time for me to understand that a simple magnesium that everybody always just supplements has a very important function in our brain, and why migraineurs really have to supplement, even if they're eating magnesium day in and day out. It's just something they need to. And then there are some migraineurs who have more magnesium than they want to from their diet, and they feel overwhelmed by the magnesium, then they reduce it or even stop it. That's fine. You just have to make sure you have enough.
Wow. So when was your first book published?
2014, so 10 years ago.
14. And you're growing, how many people in your Facebook group now?
Okay, so then 2017, I had a second book published. So that's what started to open the floodgates, because the first book was just me. It didn't contain anything from anybody else. But the second book already had a lot of migraineurs and their experiences. Great. And so I ran so many surveys and I learned so many things. And also I had included a lot of quotations from my migraineurs with their permission in that book to sort of help me explain what it was. And it was not just me, but it was thousands of other people. And so 2017, I published a second, which I called the Complete Guide, because it had everything in it that I knew up to that point. It's a over 600 pages book. It's a very big book. And
there's also another interesting thing about folks who develop programs that, and from your own experience, and that is, I'm now thinking about a doctor who had type 1 diabetes himself and is now in his 80s, Dr. Richard Bernstein. I don't know if you run across his work, But the method he has in his book is very comprehensive. In fact, it's kind of off-putting for a lot of people that it's too much to do, right? I wonder if how do you look at the most important elements of what to do? And, is electrolytes or diet or both? Or it sounds like having the salt was the highest and even was effective when you were eating carbohydrates. Is that the most important thing?
That is the most important element. But then as we went on, I discovered that there are caveats there too, because, for example, if you eat a high carbohydrate diet and you feel that you're about to get a migraine, if you take salt with water, you're going to get a bigger migraine. You need to get then salt without water, because now that I understand that that glucose removes water and sodium from the cell, so you have plenty of water, but it's all in edema. And migraineurs get edema all the time. That's one of our symptoms, that we have edema. And so if you then take salt, just salt without water, your edema is gone. But if you take it with salt and with water, you're going to get a bigger migraine. So it's not straightforward even that way. But I would say that if I had to choose between salt and anything else, I would choose the salt, because that is the primary purpose of migraineurs. There is one study that I have found from 1951 that shows that on top of everything, migraineurs are salt wasters. So we urinate the salt out much more than other people do. And that is another problem. We don't recycle the sodium. And so the combination of all these, I would say that if there's one thing you can do, then add salt just with water or without water, even if you don't change what you eat. That is going to solve, I would say, about 50 to 70% of your problems. Not all, because we still have other issues with carbohydrates. If you eat a lot, you're still going to get the edema. You're still going to get issues. So you need to manipulate and manage how you do that. Also, we have, of course, a hormonal influence, because estrogen recycles sodium, progesterone dumps sodium. So these are the mostly cycle connections. Then we have the barometric pressure connections, right? Where increased pressure is a vasoconstriction effect, and a reduced barometric pressure is a vasodilation effect. So these are all affecting your electrolytes. So we have a huge template now of what to do and when to do it and how to do it. And if the person is consistent for a number of years, now we don't know for how long it takes for somebody to be able to reset their body to the start. And by this, I mean, I am now at that point at the start for a number of years where I can go out and eat an ice cream and not get a migraine. Last summer, I spent a whole summer experimenting how much carbohydrates I can eat and get away with it. I ate watermelon all summer long, which was terrible because I'm addicted to watermelon. But that's what I was doing to experiment. And so you reach a point where none of these will bother you, but I don't know yet for how long before everything is going to return to be bad again. So that's another thing, is that you can reach, if you do everything just right to your body, it might just be salt you need. You may not need to change your diet, but how long is that going to last?
So some
change.
Self-detective work.
Right. It's major self-detective, right? So you have to modify to who you are, what you do, and how you live. And obviously, if you're an athlete, I work with a lot of athletes. It's really fascinating. Marathon runners and weightlifters in my group, competitive runners and weightlifters in my group. So that means that they also have issues, but they're very different from other people who don't. And so my work now is way past just a simple migraine. It's more specialized into these little nooks and crannies of specialties where it is very difficult. And for other people, we have people who completely recovered in the matter of 2 weeks, no more migraine. And we have people, just yesterday, I got a testimonial from somebody for whom it took 4 years to become migraine free. So
you have a Facebook group now with tens of thousands or 17,000. The book's out there for 10 years. And I remember in training some years ago, working with some headache specialists. They were using this drug and that drug. And when that drug didn't work, they go to another drug. They even talked about rebound headaches from drugs causing trouble. Have you been approached by any academic or non-academic headache or migraine specialist about this?
Oh, yes, many of them. And many of them understand what I'm saying and would like to, actually put it to good use, but it can't because obviously the Board of Medicine and the anti-salt, it's just impossible.
Well, you would start with a small study first. And have there been any studies done with your method that you have?
Not on salt.
And then has anyone helped you take the surveys of your people, your followers? We did that with a group of people with type 1 diabetes. We surveyed them, and then it actually led to a publication in the literature. And it actually was the most popular article in the journal Pediatrics that year. But it was a collaboration with a Harvard group. So there was Duke, there was Harvard, and then this Facebook group. Would you have any interest in collaborating that way?
Oh, absolutely. Absolutely. In fact, I don't know if you're aware, but I just had an article accepted, and it's not yet published because I'm just looking at the proof that I have to do. And it's called, it's in the Frontiers in Nutrition, a journal. And it's called Specifically Formulated Ketogenic, Low-Carbohydrate, and Carnivore Diets Can Prevent Migraine Perspective. So this is, I'm still reading it because it's open on my desk and it's a long title.
Fantastic. And that
I'm starting.
You're the first author?
I'm the only author. It's just one.
Authors. So Stanton, Angela, and Frontiers in Nutrition. That's fantastic. You also contributed to the textbook called Ketogenic.
Right. Correct.
Right. The Noakes check. What did you do for the Noakes textbook?
So for that one, I derived Migraine for professionals. I think it's about 2.5 pages, something like that in the books. It's not a big part, with a graph that shows the progression of what a migraine is and at what point the healthcare provider could get involved and get in and do something. So that was, and I also have several lectures. I don't know if you're aware, at the Noakes, the Nutrition Network. I think I have 5 lectures. One of them, the last one that I created, is a very big 90-minute full lecture on neuroscience in general and the health and the degenerative diseases of the brain. And so I am covering migraine as well. That's not the focus, but all the degenerative brain activities and why they happen. And so I have a lot of things going, and I have some other companies where there's a lecture for, and these are all for professional credit for healthcare professionals. And there are a couple of articles that I have published. Unfortunately, at that time when I did that, I was not yet familiar with the industry papers. I was familiar only with the papers within economics, and these 2 went to pirate papers, which I didn't know at the time. So now I know. Nevertheless, they both are being cited, interestingly, in other literature. So I have some, and of course, with the current migraines that I have, now I have 2 migraine groups. So, and I'm hoping that we're going to talk a little bit about the different kind of nutrition forms, because my main migraine group is not ketogenic. The other group is a ketogenic group. And so I...
Explain that a little bit, yeah.
Okay. So the main migraine group does not actually allow ketosis, period. So we measure the blood ketones. I actually follow Dr. Burstein's procedures of how he was doing, and also Dr. Kraft. I follow his Kraft test, but I modified it, and it's a 5-hour test, but every half hour. And instead of using insulin, I'm using ketones as a proxy. So I'm using blood glucose and blood ketones. And for the protocol group members, I don't want to see blood ketones higher than 0.4, 0.5. That's the max. They can't be in ketosis because they're taking medications. And remember my experience, I don't know which medications will interact, but we don't want any interaction. And we can't even really explain the interaction other than ketosis causes a little bit of acidity to the blood, more so than without the ketones, which are fatty acids. Nobody's talking about whether it's changing the clearance of the medication or whether it is changing the half-life of the medications. Don't know what actually is happening, but it's not clearing the observed clinical trial way. And so as long as people are taking any medication, now they can take triptan is okay. If they have thyroid medication, that's fine. Hormone replacement therapy is fine. But if they're taking medication that crosses the blood-brain barrier, no go. Absolutely. So they have to sign a waiver. I actually have a medicinal waiver of interaction for medicines in my group. Everybody who's taking medication must sign this. They need to know that there is a potential for interaction. And so we have over about 70,000 people right now in the group. But overall, in the past 10 years, if I add the people back who left because they returned to work and they left the group, we're talking 25,000 or more people. They all had to be aware and all had to sign. They even have to sign a supplemental waiver if they're taking supplements that we don't recommend, because supplements are just unregulated medicines, right? So it's a very serious group. It's not your typical everyday kind of a Facebook group. It's a serious working group. And the other group is ketogenic and keto carnivore. So the main group is low carb, high fat, and carnivore. And these two we set at a high protein level so that nobody can get into ketosis because the protein level is too high. And in the ketogenic group, the starting keto is MAD, the 411. And they can continue the carnivore diet if they wish. And I created keto carnivore macros, and they can follow that, and created also hyper carnivore, which is basically very high protein, non-ketogenic, with high enough fat, with a little bit of carbs, so they can have a pickle, say, with their burger or something like this. And so different levels. And the way that this is organized is that as long as somebody still has migraine that he or she may need a medication for, they can't be in ketosis, period. And as good as the ketogenic diet is, at the beginning, if the person doesn't know what they're doing, they can end up with killer migraine headaches. And so it's not recommended to start with that. And you know, the reason why this is because when we talk about insulin resistance, so when people have insulin resistance of diabetes, they switch to the ketogenic diet and they're doing fantastic very fast. But because they don't have a migraine brain, whatever water is and sodium is lost from their system as a result of the drop in insulin is a benefit to them. But knowing how important salt is, a drop in sodium and water is not a benefit to a migrainer. And so if we move the migrainer straight to a diet where insulin is reversed very quickly and we don't replace the lost sodium and lost water right away, and most people on ketogenic diet don't do that, then they will end up with very serious migraines.
That's interesting. You know, there's so many different versions of a ketogenic diet today. I mean, even internet keto is a term we use for what they teach out there. The main point is to be with someone who's teaching you a legitimate way of doing a keto diet. And I think my approach is, to me, it's kind of like a harsh hammer, I guess, compared to if someone comes to me. I don't take this care to worry, but it'll certainly make me pay more attention. Most of the time, people come back and tell me that their migraines in whatever form is better, and I don't tell people not to do ketosis and all. It'd be interesting to do a study to compare these different approaches, and that's the first time I've ever heard of a test where you measured glucose and ketones over time. That's pretty neat.
Right.
But the idea is to not be in ketosis.
Exactly. And you know, many people disagree with me, but I am very firm on my ground. And because I have so many people experiencing, and then many of the people who are not in my group, and I talk to them on X, formerly Twitter, or anywhere else, they tell me, well, the migraines have been reduced. Well, that's not eliminated. And so a reduced migraine by certainly welcome is not an elimination. So I go for the elimination. So I have a different purpose in mind. And I'm looking at...
Well, absolutely. And when people come to me, they want it to work the first time, every time. They don't want to mess around with approaches that may not work. there's so much that could be assessed, analyzed, and even taken to a clinical center on migraines that would be so neat if there was right now I'm thinking that a fellow a research fellow who has to have a project could help with a survey of the people who are following this approach to learn so much. Of course, when the type 1 diabetes paper was published, the rebuttal was it was just a Facebook group. I mean, even though they had better results than we ever get in our clinic, the doctor wrote, but I think Facebook group is quite legitimate as a place to start.
I totally agree.
I really hope that I'm so impressed with your knowledge and then the following of people that you've had, and then even the clinic experience in my clinic of handing out your book has been such a great value to my patients, and I hope to other migraineurs. Tell me again the book you would recommend for someone to start out with.
Okay, so the book title is Fighting the Migraine Epidemic, Complete Guide. How to prevent migraine without medicine, something like that. It's a longer title. I don't remember it anymore. But there's only one book sold. It's a big white book. It's over 600 pages, so it's a very big one. Available on Amazon, the paperback and ebook.
Fighting the Migraine Epidemic.
Right, that's the only thing they need to remember. And I'm working on the 3rd edition, which is going to be, it keeps on being postponed because the group is so busy. And for those who, just because, and many of your patients actually have come to me because they have a question in the group, how did you hear about us? And they tell me, Dr. Westman. And so I'm familiar with it. And then we have a lot of doctors in the group and other doctors who are very well known, like Dr. Sivas and some others, all send their migraineurs to me. And so the title is going to remain the same, but in the group, I have just about every single country represented on the planet. And some are surprising. Somebody just joined a couple of days ago from Mongolia. Very unusual places that you would not associate with internet.
Where do you live, Angela?
I live in Southern California.
Okay. And do you have a clinic where someone can come visit you personally?
And no, I'm not a medical doctor. I'm a scientist, so I don't have a clinic. So I don't do any diagnostic works or can't prescribe anything. So this is what I do is all voluntary. It's all free. There's no charge for any of this, and it's completely free. And people can come and go as they wish and do as they wish. And most fascinatingly, there is nearly, I would say, about 80-90% true following and adherence. We still find people in a group who've been with us for 10 years and said, oh, what group is this? But they haven't paid any attention. But of the majority who join now, we had a few turbulent years when people would come and say, what? Come on, salt, really? And there were some really bad starts, as you will know. You have a lot of industry also after you. I had some industry, particularly from certain pharmaceuticals, right? Really nasty things happened in the past, but this now sort of kind of stopped. And now people coming into the group, it's like, okay, where do I start my reading? And we have what they call the Stanton University because of the much literature that they have to follow. So it can take a good 6 months to read everything and understand and ask a lot of questions. So we are very, very, very busy. So back to the survey. I do have surveys. And it can run statistical analysis. The problem is that I don't have the time. And the second is that the bigger problem that I face, and actually I even faced during the publication of this one article that is now going to publish from one of the reviewers, is that migraine is considered to be medicine deficiency, and you're familiar with this.
So is diabetes, right?
Exactly. All of these, and of course, migraine is so connected to metabolic disease. I mean, we know that it is, that it is considered to be medicine deficiency. So it's simply just swept up.
I bet, time passes and of course it took 15 years for this recent paper on low-carb diets for irritable bowel syndrome that just came out. Our paper was published in 2009, 15 years ago. But I bet there'll be a doctor, especially one maybe who got into the migraine field because of his or her own migraines who will come around, and so hang on, always still be optimistic, and I just want to thank you for what you've done. It's again, it's based on your own experience, yet then spreading the word through simple tools as books and food and nutrition. It's amazing. And so unbelievable, people don't believe it. So
Exactly. Very well put. They don't believe it.
again, I hope we can talk again down the road. In the meantime, I look forward to your emails that go through on the listservs that we're on together.
Right.
I'm learning as we go. And again, thank you for your time today.
Well, thank you for inviting me. It was really a pleasure talking to you. Very exciting.
And that will be where they end. Thanks again. I am. Anyway, I'm blown away with the things that, medicine deficiencies. Where are you from originally?
I'm from Hungary.
Hungary. Okay. And when you were at the initial universities you were at?
I was here at UCLA. I started at UCLA.
Oh, UCLA. But then you were in Germany.
Well, after my PhD, I went to Germany after I was teaching at Chapman University locally. And I was very unhappy because of my teaching there. And I quit and went to Max Planck in Germany to the institute. I was not as a postdoc, basically, sort of kind of working on research at the time. And my research was in neuroscience, the hormonal response to the environment. I would make people sniff oxytocin, for example. That was one of my clinical trials, and vasopressin was another one. And I would see how their decisions were changing. So actually, the connection of oxytocin to generosity, which is now called the love hormone, is my dissertation.
Wow.
And so that was, after this, I went to Germany.
How do I turn that down? I don't want to be so generous anymore.
Vasopressin. But of course, it's really fascinating because we give people vasopressin because of urinary issues, right? But vasopressin makes people stingy, really stingy. It's really fascinating. It's part of my dissertation. Chapter 3.
Can I get an herbal form of it?
No, it has to be the real stuff. And it has to be refrigerated and kept in such a way that it actually retains its potency, because both vasopressin and oxytocin, both of them just very quickly evaporate their strength.
So, of course, the video is over, but of course, this gets into magnets, doesn't it? Magnetic fields.
For magnetic field, yes. I'm very much into all of these and studying everything and trying to tell people to not be scared of the electromagnetic field of the telephone. And all this kind of thing is just really fascinating.
But does the transcranial magnetic stimulation, that kind of the dumbed down ECT for
it does. It does temporarily. And so you can, depending on the kind of electricity that you put through. But for example, you can create the kind of electricity that can initiate an electrical activity in your brain. Obviously, that's, and in fact, in depression, there was a study, and there's only one, and I don't remember anymore the title, but in that there was, I think, 4 people, live humans, who volunteered for the experiment with clinical depression. They literally opened their brains and they sunk down. That was at the time I was with Berkeley looking at animals where we put single electrodes into the brain and looking at single neurons, how they responded to certain stimulus from the outside that would make them respond, want more or want less, or be generous, or that kind of stuff. And so these people have single electrode and pushed down into their amygdala deep inside and stimulated, and their depression disappeared, lifted for the kind of period that it was stimulated. So you can create electricity that can cause a whole lot of things, but you can also stop the brain from working. But some of the things that people fear today, they're not meaningful. So yeah, I mean, all of that.
I've thought that I had a family member who had ECT and for depression, and I mean, it was night and day.
It can be.
The thought is that it's maybe the chemical, neuronal, or the hormonal release. And I think I thought it was, thinking about it and reading about it, that it might even be the magnetic field generated by that electricity.
But you're familiar with the device, Cecily? I don't know if I pronounce that properly. It's a device that people put on for migraine. And what it does, it basically is magnetic, and it sends a current through the brain. And it does stop migraine. But of course, when you take it off, it stops working, obviously.
That burns.
So, I mean, the fact that our brain is just pure electricity, and I understand depression to be also a problem of electricity. And whether salt can help on that or not is another question, because there's no way to put salt into the amygdala, right? I mean, it has to someone get there. And if the avenue is broken, there's nothing you can do. But clearly by starting the electricity in the brain, in the amygdala, and that was not an ECT, but that was just a single electrode. But the ECT, to the same way. And of course, it can also be damaging, because if you don't have that problem, it can cause major havoc as well.
So my prior life, I actually, first half of my career was working with a neuroscientist. He is really into nicotine.
Oh.
He was actually inventor of the nicotine patch. And he's in Durham. I talk to him, every few months now. I don't work for him anymore, but a lot of, how about smoking and migraines? I mean, the nicotine itself.
That was a clever guy with the nicotine patch. That's a really fantastic invention.
Yeah, well, I got to run, and I thank you so much for interviewing, and let's stay in touch, okay?
But absolutely. Thank you so much, and I hope you have a great day. Thank you. Bye-bye.
Yeah.
If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.